Hi, welcome to this education session in the MedEssist Education Hub titled Antimicrobial Stewardship in Primary Care and How to Review Antimicrobial Therapy. My name is Stephanie Shea, and I'm a antimicrobial stewardship pharmacist currently working in a hospital. I often get asked by my colleagues on where they can learn more about antimicrobial stewardship. This was one of the main motivators of me creating this session for you. I hope to introduce you to the principles of antimicrobial stewardship, including what it is and why it is important. We will explore some antimicrobial stewardship strategies that primary care and community pharmacists can use when reviewing and or prescribing antimicrobial therapies. I will also share my systematic thought process for reviewing antimicrobial therapy that you can adopt in your practices. My goal is to equip every one of you pharmacists with the basic knowledge and skills to be antimicrobial stewards so that we can all contribute to the fight against antimicrobial resistance. After completing the session, participants will be able to explain what antimicrobial stewardship is, describe at least 2 reasons why antimicrobial stewardship is important, apply antimicrobial stewardship strategies when prescribing and reviewing antimicrobial therapies, and to apply antimicrobial stewardship strategies when monitoring your patient's therapies. We'll start off by addressing the question why antimicrobial stewardship is important and what it is. Then we'll go through some antimicrobial stewardship principles that you can apply in a primary care setting. I will then share my systematic thought process on reviewing and monitoring antimicrobial therapies, then end the session with a few key takeaway messages. So you may ask, what is antimicrobial stewardship? If we break it down, antimicrobials refer to the antibiotics, antivirals, antifungals, and antiparasitic agents, basically medicines used to treat infections. Then when you look at the second part of the word stewardship, this refers to the job of supervising or taking care of something. Therefore, putting it together, antimicrobial stewardship refers to the job of optimizing antimicrobial prescribing to ensure that antimicrobial therapies are prescribed judiciously and to ensure that the right indication, right antimicrobial agent at the right dose and duration are selected. You might ask why antimicrobial stewardship is important. By ensuring the judicious use of antimicrobial therapy, we reduce their overuse and inappropriate use, which reduces antimicrobial resistance. Antimicrobial resistance has been identified by multiple organizations, including the World Health Organization and the Centers for Disease Control and Prevention, the CDC, as one of the greatest public health threats. Antimicrobial resistance alone led to an estimated 2 million infections and 23,000 deaths per year in the United States. Overusing antimicrobial agents is one of the most important modifiable risk factors contributing to this problem. When antimicrobials are overused, the bugs change over time and will develop resistance. Antimicrobial resistance increases morbidity and mortality because infections become increasingly more difficult and even impossible to treat with the current therapies that we have available. And we can't count on the ongoing clinical pipeline because it is currently running dry of coming up with new and novel antimicrobial agents. Without effective antimicrobials, the success of modern medicine in treating infections, including doing major surgery and cancer chemotherapy, would be at increased risk. A Lancet 2019 systematic review assessing the burden of antimicrobial resistance in 204 countries and territories found that there was an estimated 5 million deaths associated with bacterial antimicrobial resistance in 2019. The 3 infections that contributed most to this mortality were lower respiratory tract infections, bloodstream infections, and intra-abdominal infections, which is depicted by this bar graph. Together, these 3 types of infections accounted for around 80% of deaths attributable to antimicrobial resistance in 2019. If you just look at the lower respiratory tract infections alone, this accounted for more than 400,000 attributable deaths and 1.5 million associated deaths. The second reason that practicing antimicrobial stewardship is important is to reduce the side effects of antimicrobial therapy, including Clostridioides difficile infections. Antibiotic treatment is the most important risk factor for C. difficile infection. The CDC identifies C. difficile as an urgent public health threat. It estimates that C. difficile infections in 2017 attributed to 12,800 deaths and costed the healthcare system approximately $1 billion. Recent data has shown that while healthcare-associated C. difficile cases are decreasing, community-associated cases are not. And strategies to reduce C. difficile infections include reducing and improving antibiotic use, such as practicing antimicrobial stewardship. In Canada, it has been estimated that over 90% of antibiotic dispensed are used in the community, and up to 50% of antibiotics prescribed to patients in the community may be either inappropriate or unnecessary. As pharmacists, we review all prescriptions prescribed by clinicians, and therefore we're in a perfect position to be antimicrobial stewards. This is even more so as we are provided with expanded scope of prescribing for minor ailments involving antimicrobial therapies, such as urinary tract infections, tick bites, and oral thrush. As antimicrobial stewards, pharmacists can help maximize the benefits and minimize the risks of antimicrobial therapy when needed, and provide education to patients on non-antimicrobial treatment options for infections where there is no effective antimicrobial therapy available, such as for the common cold. Antimicrobial stewardship strategies that pharmacists can use when reviewing prescriptions and prescribing for minor ailments, such as urinary tract infection and tick-borne illnesses, include the use of antibiograms, identifying bug-drug mismatch, de-escalating therapy, optimizing antimicrobial dosing, improving documentation on prescribed antimicrobial therapy, and systematically verifying antimicrobial allergies. A quick acronym to remember these strategies is the ABCD plus allergy and documentation. The first strategy outlined is the use of antibiograms. Antibiograms are developed by the microbiology lab and provide a summary of bacterial isolates and their susceptibility profiles within a specified time period. Its purpose is to help you choose which antimicrobial agent you can use with the most likelihood of treating the infection when you don't have any patient-specific microbiology culture data. Antibiograms can vary from institution to institution, even within the same city, because of the differences in the population. LifeLab releases antibiograms annually for British Columbia and the Ontario region, and can be found on their website. So here I give an example of LifeLab's antibiogram for the period of January 1st, 2022 to December 31st of 2022. And I'll briefly go over how to use this. If you look at the first column, this indicates the organisms that were included in the antibiogram, such as E. coli, Enterococcus, and the group B Streptococcus. The second column shows the number of isolates that were included in the development of this antibiogram. And the remaining columns of the antibiogram to the right depict the antibiotics that were tested and the isolated organisms' susceptibilities to them. For example, if you look at the row for E. coli, you can see that 98% of the isolates during this time period were susceptible to nitrofurantoin, whereas only 74% of it was susceptible to ciprofloxacin and 82% of it was susceptible to Septra. Therefore, this gives you an idea of your local area's susceptibility patterns and therefore can be used to guide empiric therapy. However, it should not be the only thing to consider when selecting your antibiotic empiric therapy regimen. A patient's particular infection history, including their past culture results, if available to you, and antimicrobial use must also be considered. Bug-drug mismatch refers to a situation in which the antimicrobials that a patient is receiving does not provide adequate therapy, e.g., it is resistant for the identified organism presumed to be causing the clinical infection. Looking for bug-drug mismatch is a reminder of the importance of following up on culture results and susceptibility profiles if one has been ordered, and using the culture data to modify and optimize your patient's antimicrobial regimen. Changing therapy to an effective therapy earlier can help expedite the change to appropriate treatment and therefore improve your patient's outcome as well as shorten the total number of days of the antimicrobial regimen duration. De-escalating therapy refers to the use of a narrow-spectrum antimicrobial to treat the patient's infection. There are two scenarios to consider here. For empiric therapy, and this refers to when you are starting antimicrobial therapy without culture results available, such as if you're suspecting a cystitis in your patient. De-escalation of therapy means that you're picking the agent with the narrowest spectrum of antimicrobial coverage that will most likely treat the infection and nothing more. For targeted therapy, this is when you have culture results of the infection that you are treating back. De-escalating therapy means you're changing the antimicrobial agent to the narrowest spectrum to target the isolated bug. Next, paying attention to the dose of the antimicrobial is also very important when treating an infection. A dose that is too low will compromise the chances of successfully treating the infection and may increase the risk of developing resistance. A dose that is too high, however, can increase the patient's risk of adverse effects. Therefore, it is important to optimize the antimicrobial dosing to the patient's characteristics such as their weight, renal and liver function, to the site of infection, such as making sure that the dose that we give will reach the site of infection in adequate concentrations to be effective, and to the drug's characteristic, such as considering its pharmacokinetics and pharmacodynamics characteristics, such as whether it exhibits concentration or time-dependent activity. Documentation is always considered best practice, making sure that the indication, i.e. the infection, duration, reason for therapy modification, and or culture results for all antimicrobial prescriptions written are documented help remind us to consider that these crucial factors when assessing antimicrobial therapy. A review study found that documenting the indication for antibiotic therapy improved prescribing and patient outcomes, and that documenting indication for all antimicrobial prescriptions has been associated with a 18% absolute reduction in antibiotic prescribing. Systematically verifying a patient's antibiotic allergy is also best practice and definitely falls within a pharmacist's scope. By accurately identifying and documenting a patient's antibiotic allergy history helps reduce prescription of more toxic, costly, and less effective antibiotics. Allergic reactions to antimicrobials are often overreported by patients, since many reactions are actually adverse effects and not true allergies. Keeping your patient's allergy profile accurate and up to date at all times is extremely helpful for other healthcare members within the patient's circle of care, and this includes hospital pharmacists when the patients are admitted into the hospital. Now that I've gone through the antimicrobial stewardship strategies that you can utilize, I want to share how I review antimicrobial therapy and how to incorporate these stewardship strategies in your thought process. This is likely going to be a review for all of you. Instead of introducing new concepts here, I want to bring back some of the systematic thought process that were instilled in us in school. That is with the NESA approach. So NESA stands for necessary, effectiveness, safety, and adherence. I use these four core principles of assessing any drug therapy to review my antimicrobial therapies as well. And I always make sure to go by this order because we want to assess whether a drug is necessary or that there is an indication for it before reviewing the therapy further. Once we determine that there is a need for the therapy, then we go and assess the other aspects of the therapy, such as its effectiveness, safety, and adherence. The difference when using these factors to review antimicrobial therapies is that we need to consider three things. We need to consider the bug, drug, and our patient. Note that this is a general systematic thought process that I use that will not necessarily capture all of the clinical nuances for every patient scenario, as every patient is unique. It is important to still use your clinical judgment when applying this thought process to each of your patients. This is also what works for me. As you become more comfortable assessing antimicrobial therapies, you may end up tweaking or developing your own thought process in the future. The first factor to consider is necessary. For this factor, we are completely focused on our patient. I think the cool thing about minor ailment assessment is that pharmacists get to wear a diagnostician hat. I find that approaching a patient with a diagnostician view feels more like putting together a jigsaw puzzle That is, you're trying to put together the different pieces, like the patient's signs and symptoms and their blood work, in an attempt to come to a unifying diagnosis to explain all of these different findings. This is a little bit different from when you receive the prescription for a diagnosis that has already been made. In this case, all we're just doing is scrutinizing the prescription for any drug therapy related issues. Being a diagnostician requires us to take a step back and to look at the bigger picture. Step back from the detail. Start from a blank slate. Assess the patient as a whole, and then start fitting together the pieces as you gather the information. So the things that you're looking for here include the patient's signs. This refers to things that you can objectively measure, such as if the patient reports a fever, and other signs include if the patients have access to their lab or imaging results or blood work that they're willing to share with you and that you can look at. The patient's symptoms. So this refers to those symptoms that are subjective to the patient, things that you can't objectively measure. This includes if the patient reports suprapubic tenderness, dysuria, and chills to you. Now, putting together the patient's signs and symptoms and the patient's blood work or imaging results, if you have these available, you can now refer back to your therapeutics lecture courses back in school to see if you think that there is an infection or an indication that requires antimicrobial therapy. If no, then your assessment can stop here. No indication for a medication equals no need for a prescription. If yes, then proceed to assessing the medication part. Again, we want to consider the patient, drug, and bug when assessing effectiveness. If we consider the patient factors first, we want to keep in mind the infection that we're treating. We want to also consider the patient's past medical history, such as their weight, use of concurrent medications to assess for any efficacy-related drug interactions. Next is the bug. Based on the infection, what are the common bugs implicated? This is important to consider because this will influence the antimicrobial agent that you pick. So now we look at the drug. What antimicrobial agent will be effective against these common pathogens that we're targeting? This is when you can use some of the antimicrobial stewardship principles that we mentioned earlier, such as using the antibiogram if you're treating the infection empirically, and making sure to pick the narrowest spectrum antimicrobial agent, i.e. de-escalate, that will just be enough to treat this infection. We also want to optimize the dose for the infection as well as to the patient. What is the lowest effective dose adequate for the infection that will allow adequate penetration to the site of infection? Will the drug even penetrate to the site of infection at all? And will the dose be effective based on the patient's kidney and liver function or weight? And also consider whether there's any drug interaction that will affect efficacy. Next, we consider safety. Looking again at the patient-specific factors, we want to consider their past medical history to determine if they have any kidney or liver impairment or any conditions that will make the antimicrobial therapy be a contraindication. Are there any drug allergies? And are they on any concurrent medications to determine any safety-related drug interactions? In terms of the drug factors, we can again apply the stewardship principle of dose optimization here. We want to assess if the dose is safe for the patient's kidney and liver function as well as their weight. Next, we assess for patient adherence. From the patient's perspective, can they adhere to the regimen? Can they afford it? Is the formulation appropriate for them to take? For example, can they swallow tablets? Are they being enteral fed? And if so, can the formulation be given via enteral tube? In terms of the drug factors, we want to also consider cost. Can the patient afford this? After completing your review and assessment, remember the ASP or antimicrobial stewardship strategy of antimicrobial documentation. We want to document at a minimum the infection that we're prescribing the antimicrobial regimen for, the duration of therapy, the reason for therapy modification, and or culture results for all antimicrobial prescriptions written. After we send the patients off with their antimicrobial therapy, it is so important for us to follow up or educate the patient on how to monitor their therapy to ensure that they are improving and not experiencing side effects. Remember back in the days when we used to create monitoring plans in school? This is it, but applied practically. At school, this can be a bit of an abstract concept as we didn't really have much direct patient care experiences, or at least it was to me. To make this concept simpler for students or new grads, let's put monitoring in another perspective. Ask yourself, If I had this infection that I am taking this antimicrobial therapy for, how would I know that this medication is working for me? What would I monitor for? By asking yourself this, I hope that this will help you identify the effectiveness and safety parameters for your patient. For effectiveness parameters to monitor, since not all patients present the same way, we want to know if their initial signs and symptoms that they endorsed are going back to their baseline. For safety parameters, you'll need to look up the common or rare but serious side effects of the medications that they're taking if you're not already familiar with them, so that you or the patient know what to look for. For example, since we know that C. difficile diarrhea is associated with antibiotic use, we should ask our patient if they have noticed any diarrhea or have them monitor for this after starting the antibiotic. Unfortunately, C. difficile diarrhea can occur within 3 months of stopping the antibiotic. So we can also educate our patients to monitor this themselves after they stop the antibiotic and inform them to go see their family doctor if they experience this, especially within 3 months of stopping therapy. If the patient, for whatever reason, had a specimen collected for culture for this infection, then it would also be important to follow up on the susceptibility report to ensure that the antimicrobial therapy is effective and to identify any bug-drug mismatch. In conclusion, I hope that everyone has taken away the following points. Antimicrobial resistance is a global threat, but we can all be antimicrobial stewards to reduce antimicrobial resistance. We can review antimicrobial therapy by using what we already have in our knowledge toolbox, namely using the NESA thought process and incorporating the patient, bug, and drug into this assessment. Lastly, remember to apply the antimicrobial stewardship strategies into this thought process, which can be easily remembered as the ABCD plus documentation.